Thank you very much for this kind introduction, and I also would like to thank the organization for inviting me. It's a big honor to be here. I will talk about treatment of older patients with head and neck cancer, and I will also speak about the EORTC RAVINA trial that will start soon. These are my disclosures. I will speak about epidemiological trends. We will see more patients, older patients with head and neck cancer. I will talk about priorities of the patients, about the efficacy of our standard of care, and about geriatric assessment and interventions, and about dedicated studies for older patients. Speaking about older patients with head and neck cancer is important because we will see a strong rise in the coming years. This figure shows the situation for the United States for oropharyngeal cancer. And you can see here in blue patients who are over 75 years of age. And in red are patients between 64 and 74. And you can appreciate here that in 2010, only a small proportion of the patients were in the oldest age category. But in the next years, up until around 2035, we will see a strong increase in the number of older patients. This is also true for Europe. Estimations for 2020 were that in Europe, about 30% of the patients that were diagnosed with head and neck cancer were already over 70 years of age. And I looked it up for Norway, it's even higher, it's 45%. And what can we expect between 2020 and 2040 for all men in general diagnosed in Europe with head and neck cancer? This number will rise by 13 to 22%. But looking at men over 70 years of age, the number of diagnoses will rise by 50%. And all patients who are older differ from their younger counterparts because they have reduced organ reserve, reduced kidney function, for instance, reduced cardiac function. They are more likely to have comorbidity like COPD, cardiovascular disease. They more often use a lot of medicines. They have a higher risk of being frail, and I will come back to that. And older patients can have different priorities for treatment outcome. This is a study that was done in the Netherlands among 170 patients with a median age of almost 78 years with head and neck cancer. And they were asked about their priority. And for the most patients, maintaining independence was their first priority. So it was not extending life, but maintaining independence. Looking a bit further in their second priority, then we see that in this group of patients who had maintaining life as their first priority, extending life was for most the second priority, but also reducing symptoms like pain and other symptoms was an important second priority. And for the patients the 1/3 of the patients who had life extension as their first priority, life extension as the first priority, the maintaining independence was the second. So maintaining independence seems to be a very important priority for all patients. But what do we know about efficacy of our standard of care for older patients? To look at that, we have to go to the meta-analysis of clinical trials and look at subgroup analysis of trials that have been done. This is a meta-analysis, which means that a lot of trials were looked at together. And in this figure, all the dots that are on the left of this line mean that chemotherapy, in addition to local treatment, is better than local treatment alone. And this is divided by age. Here at the top, we see that patients who are below 50 years of age, they have clear benefit from adding chemotherapy. And here we can see that at 5 years, the life expectancy is increased by almost 10%. But if we go down to, for instance, patients between 61 and 70, this difference goes down to 3%. And for the oldest age group, those of 71 or older, the benefit is almost gone. I have to say that there is only a very small proportion of patients who are over 70 in this study, only 7.5%. And these are old studies with old-fashioned radiotherapy and different kinds of chemotherapy, but still it's the strongest evidence that we have. On the other hand, there are also studies that are retrospective studies that show that chemoradiotherapy is feasible in older patients, and that when you treat patients with chemoradiotherapy, they have a longer overall survival than when you treat them with radiotherapy alone. However, these kind of studies, the retrospective studies, always have the selection bias, because the patients that are the most fit will have received chemoradiotherapy, so they have a better prognosis from start. Then looking at cetuximab, that was introduced already in the previous talk. It's EGFR inhibitor that can be given together with radiotherapy. Here is a subgroup analysis of the Bonner trial, where, like in the previous graph, you can see here on the left, there's a benefit from adding cetuximab to radiotherapy for those under 65. But if you look at the subgroup that is over 65, it seems to favor radiotherapy alone. This is a subgroup analysis, so we cannot draw conclusions from it. It's only hypothesis generating, but at least we don't have a proof that for older patients this is effective like in the younger patients. This is a meta-analysis of a lot of radiotherapy studies, where also an old meta-analysis from 2006, where they looked at altered fractionation schedules compared to conventional radiation. And it's striking that here you see the same pattern as in the chemotherapy studies, that patients who are younger than 50 years of age have the most benefit, while the older patients do not seem to have benefit. So we can conclude from these clinical trials that older patients are underrepresented in clinical trials, that older patients do not benefit to the same extent from treatment intensification as younger counterparts. And potential reasons for this are that older patients can suffer from excess toxicity. They can have competing mortality, other diseases, and also patients, of course, can die just from older age. And it can also be that we do not select patients adequately to give them more intense treatment. And the question is, can geriatric assessment identify those patients that do benefit from more intensive treatment? Geriatric assessment is a battery of tests that looks at functioning of patients at several domains: the somatic domain, psychological, cognitive, social, and functioning. And these tests are sometimes questionnaires, sometimes physical tests to test strength. And geriatric assessment can identify health problems that were not known yet. It can be used to estimate residual life expectancy. It can predict treatment tolerance, support treatment decisions, and it can also be used to guide geriatric interventions. When patients have deficits in one or more of these domains, they can be frail. And frailty has several definitions. They are all very complicated, like this one: a state of increased vulnerability to poor resolution of homeostasis following a stress, which increases the risk of adverse outcomes, including falls, delirium, and disability. For myself, I translate this as frail patients are less likely to recover uneventfully. But what do we know about geriatric assessment in patients with head and neck cancer? Frailty is associated with reduced survival. On the right, we see a graph where 100 patients that were treated with radiotherapy alone or chemoradiation just underwent they used the G8. It's a very short screening questionnaire with just 8 questions, dividing patients in fit and vulnerable. And you see that the vulnerable patients have a worse outcome, survival, compared to the fit patients. There were also several studies who looked at frailty and quality of life. Patients who are frail have a worse quality of life before treatment, during treatment, and after treatment. They stay longer in hospital, they have more post-operative complications, they are less likely to complete chemoradiotherapy, and they have a higher risk of being dependent on tube feeding. And have more risk of side effects of chemotherapy. So it's clear that frailty has prognostic value. But if you act on these deficits, does it help? So there were 2 relatively large trials, not in head and neck cancer specifically, but it was a study in more than 600 patients who had a solid tumor. And were starting chemotherapy, and they were randomized between standard of care or standard of care plus assessment by a geriatrician and institution of guided interventions if there were problems. And you see here that the group that had geriatric interventions had a reduced risk of grade 3 or higher toxicity from chemotherapy. There was a 10% reduction in risk. The second study in more than 700 patients showed the same, but actually an even larger difference of 20% reduction in grade 3 or higher toxicity, and they also show fewer falls. But these 2 studies, as well as other studies, have shown that geriatric interventions do not reduce emergency department visits or unplanned hospitalization. They do not reduce the duration of stay in hospital, the risk of post-operative complications, and importantly, they do not improve survival. And there is some conflicting evidence on completing chemotherapy. There was one study that was specifically done, a prospective trial in patients with head and neck cancer. These were older patients who had a macroscopic diagnosis of head and neck cancer, and they were waiting for histological confirmation. And then they were enrolled and randomized also between standard of care or standard of care plus assessment by a geriatrician, and the geriatrician could then advise interventions. The primary hypothesis of this study was that the geriatric assessment and interventions would improve overall survival, improve functional status of patients, and also nutritional status. And unfortunately, this trial was negative. Last year at ESMO, the quality of life analysis of this trial was presented, and also this was negative. It does not help to improve quality of life. There are several limitations to this study. For instance, the percentage of patients that was frail was quite low, and also the adherence to the interventions was not optimal. But there's also a more fundamental question, is whether frailty is reversible, and it probably is not. So what can we conclude about frailty and geriatric assessment? Frailty is a prognostic factor for overall survival and for quality of life and other endpoints in patients with head and neck cancer. There are currently no data to support that geriatric assessment can guide treatment decisions, at least not for locally advanced disease. Geriatric assessments and interventions can reduce chemotherapy toxicity, but they do not improve survival or quality of life. So we need studies that are specifically designed for older patients to get more information on how we should treat them. I will present 4 trials that were done or are going to happen in patients with locally advanced disease. including the Ravina trial. The first trial that was done and has already been completed is the ELAN-RT study from France. Here they investigated a de-escalation regimen for radiotherapy. The experimental arm used hypofractionated split-course radiotherapy, and they investigated if this was non-inferior compared to standard radiotherapy. The primary endpoint was local regional control, and this study was positive, but there were some concerns about overall survival. To my knowledge, there is not a full paper out yet, so we have to wait for the details. Another trial that investigates a de-escalation strategy is the NEVER trial. Here it is a single-arm trial with radiotherapy to non-elective sites only. This will be done in 100 patients and also has local regional control as the primary endpoint. This study is still ongoing. So the ELAN-RT study and the NEVER trial investigate opposite de-escalation strategies. In the ELAN-RT study, they reduce the number of fractions and the total dose, while in the NEVER trial, the volume is reduced. Then treatment escalation studies. The first is the NanoRay 312 study. This is a study that investigates intratumoral injection of hafnium oxide nanoparticles. This is a radiotherapy enhancer in combination with radiotherapy with or without cetuximab. This is a very large study. It's in 500 patients, and it's still ongoing. And then the Ravina trial, the EORTC study that will start soon. And I will show some details in the next slides. This trial investigates the addition of xevinapant to radiotherapy. And this picture shows what xevinapant does. It is a radiotherapy sensitizer, which means that it improves the effect of radiation. When cells are irradiated or you give chemotherapy, there is DNA damage. And if there is a lot of DNA damage, cells will die. And this is called apoptosis. And this is regulated by mitochondria, that is shown at the top. They activate a pathway with caspases. And here are proteins that inhibit apoptosis. So these proteins prevent cells from dying after they receive radiation or chemotherapy. And what these drugs do is that they release this brake from apoptosis, so they promote actually cells to die when they are damaged. And this is what you want in the tumor. A previous study was done with xevinapant. This was a study where it was combined not with radiotherapy alone, but with chemoradiotherapy. This was a study done in France with 48 patients in each arm. It was a placebo-controlled study. So they received standard radiotherapy with standard cisplatin, 100 milligram per square meter, 3 cycles, and in addition, xevinapant or the placebo. And the primary endpoint of that study was local regional control at 18 months, and that was better in the experimental arm that has been published. And this was the update that was presented at ESMO last year, showing the 5-year overall survival data. And you see here an impressive difference of 25% better overall survival in the patients who received xevinapant. So that made us hypothesize that adding xevinapant to radiotherapy alone could also improve the effect of radiation without chemotherapy, and that it could be an interesting approach for older patients. So we will randomize newly diagnosed older patients with head and neck cancer, locally advanced disease. And they will be randomized 1-to-1 to xevinapant, 3 cycles during radiotherapy and 3 cycles after radiotherapy, or the same regimen with a placebo. And the primary endpoint of the study will be local regional event-free survival, and events are shown here. Local recurrence is an event, regional recurrence, so in the lymph nodes of the neck. If there is a new head and neck cancer in the field that was irradiated, if there is residual disease after treatment, including if there's a salvage surgery is needed, and death from any cause. It's a large trial. We will enroll 230 patients. So it's a study that will be done in 10 countries, in 27 sites, also 2 sites in Norway, Oslo and Bergen. It's for patients who are 70 years of age or older, who have a good performance status. They should have measurable disease, and the intention to treat should be with curative radiotherapy. If they are not going to participate in the trial, it should be radiotherapy alone. That's needed to be enrolled in this study. There are 2 radiotherapy schedules possible. They are almost alike. There's one slightly accelerated fractionation. That means 33 fractions, and the standard fractionation of 35 fractions. It's a period of 7 weeks, 5 days a week. Xevinapant is an oral drug, a solution that can be swallowed or given by a feeding tube if necessary, and it's given on day 1 to 14 of every 3 weeks. We wanted this study to be a very pragmatic study without a lot of extras to make it feasible for older patients. So not a lot of extra imaging, just a CT or MRI before start that all patients will have as their standard of care, and a scan after completing treatment. I think that's also standard of care everywhere. And in this study, that will be the week after they finish the adjuvant treatment. And upon suspicion of recurrence. There will be some hematology and chemistry at screening and at each cycle and at the end of treatment for safety reasons. And the follow-up is by clinical assessment, including endoscopy. There's no endoscopy needed for oral cavity cancer. And this will be done every 12 weeks for 3 years. We have also included a limited geriatric assessment. We will do the Charlson Comorbidity Index that looks at comorbidity. We'll do that only once at baseline. And the other tests will be done at 4 different time points. The G8, the screening questionnaire with 8 questions. We will investigate instrumental activities of daily living. That's asking, can people do their own finances? Can they do phone calls, etc.? So investigating how they manage in daily life. We'll ask questions about their social situation. Are they independent, living on their own, or do they need help? We'll do the gait speed test. This is a test where you just measure the time that it takes for patients to walk 3 or 4 meters, and then you can calculate a score. We'll do this at baseline after patients have finished the concomitant treatment, so the radiotherapy part, after the adjuvant cycles, and 6 months after the total treatment. We'll also assess quality of life at the same time points with the EORTC QLQ-C30. I think this is a very well-known quality of life questionnaire. And a selection of questions from the head and neck 43, because all these questions were thought to be too much. We will collect archival tumor tissue after the trial has finished to do translational research. This has not been detailed yet. And we will collect blood samples on the same 4 time points as the geriatric assessment and the quality of life. Also to do, for instance, ctDNA analysis after every patient has been included. So we hope to activate the first site this month and enter the first patient in October. This study will run for approximately 3 years to include all these 230 patients. And in addition, the follow-up of 3 years that will take until September 2029. So, concluding from all of this is that the number of older patients with head and neck cancer is increasing rapidly for the coming, at least 15 years. Maintaining independence is the most important priority for older patients. And they do not seem to benefit to the same extent from treatment escalation as younger patients do. We have seen that frailty is a prognostic factor, but that there is no evidence that geriatric assessment can guide treatment decisions for patients with locally advanced head and neck cancer, and that geriatric interventions can reduce chemotherapy toxicity but do not improve quality of life or extend survival. So we need dedicated trials for older patients. This is essential to get the answers, and these trials have been initiated. Thank you very much for your attention, and I'm happy to take questions.
Thank you. Are there any questions from the audience? It's kind of depressing. I'm 65 years old, so and I listen to the point that frailty is not possible to stop. But we are told, all the elderly people, that we should start training both mentally and physically, and there is a lot to do to stop the frailty.
Yes,
so
that's right. Yes, well, frailty is defined by loss of certain functions. So older patients can, of course, be very fit. I had the picture of the two older people at the start of my presentation. One was still running marathons, and the other patient was dependent on, could not walk on her own. So there's a huge difference between older patients, and that difference is much bigger than for younger patients. So that makes it, so we need personalized treatment for tumor characteristics, but we also need personalized treatment for how patients are functioning, and adjust our treatment to also their priorities and what they can handle. Mm. Yeah.
And that leads me to the question about what kind of people that will be included in this Ravina trial. Is that the marathon runners and
that's a very good
question.
Frail
people?
So the frailty is not an in- or exclusion criterion. It's a stratification factor, which means that we will make sure that in each treatment arm, the same number of frail patients will be included. But you may have noticed that the performance status should be 0 or 1, which means that they are quite fit. This is something that was discussed a lot when we thought about the design of the trial, because from one side you want to be the study as close to the real-world population as possible, so that it will tell for the real-world population what you can expect. On the other hand, we know that patients who have a worse performance status have a worse prognosis, so it makes your trial more heterogeneous and more difficult to calculate what you can expect. So for now, we have chosen to include patients who are relatively fit, but well, we have to see how the trial will enroll, and this might be something that we need to change during the trial.
Yes, wait a moment for the microphone. So it is Hanne who would like to ask a question.
Just wondering, thank you for a very interesting talk. Just wondering about the toxicity of Xevinapant. Is it?
In the trial with the chemoradiotherapy, they saw that there was a bit more anemia and fatigue. And mucositis, because it's a radiotherapy sensitizer, the effect of radiotherapy locally is probably a bit worse. But this was all temporary, so and it was they could handle it very well. So there's not a big worry about that. That trial was with conventional radiotherapy, and that was one of the reasons. So we will not include proton therapy, for instance, because there are no data yet of this combination with proton therapy, and not very altered schedules like hyperfractionation and very accelerated radiotherapy, because we don't know what the interaction will be.
Thank you.
Yes, more questions? We should probably ask the Norwegian experts, but why, how come that there are so many old people in Norway, more than other places?
Well, yeah, I don't know, of course, but what I saw is that this is mainly driven by lip and oral cavity cancer. This is a combination in this registry, and there, for Norway, 50% of the patients are over 70 years of age. For the other sites, it was lower.
Yeah. Thank you very much.
Thank you.
Yeah.